Breast cancer. Breast cancer is found in asymptomatic women on screening mammography or can be found on palpation of a mass by the patient himself, herself, or the physician. Uh, when the breast cancer presents as a palpable mass, it is hard to touch. It may also be associated with retraction of the nipple because of ligaments of the breast will withdraw and pull the nipple inwards. Biopsy is the important test for the diagnosis. It can be done by fine needle aspiration, open biopsy, or a core needle biopsy. Open biopsy is a crude method and allows for the frozen section to be done while the patient is in operating room following immediate resection of the cancer. Fine needle aspiration is usually the best initial biopsy, and false positive rates are less than 2%. However, because FNAC is a small sample, the disadvantages of having a false negative high rate. Core needle biopsy is the largest sample of the breast. It is most deforming, but you can test for estrogen receptor and progesterone receptor HER2 new, and difficulties include greater deformity with the procedure with the possibility of needle will miss the lesion. Mammography is indicated to screen the breast cancer in general population starting at the age of 50 years, and ultrasound is for the clinically indeterminate mass lesion. It tells whether it's a cyst versus a solid lesion, and uh, and to see the variation of the size of the tumor. And PET scanning to determine the content of the abnormal lymph node, not easily accessible to biopsy, and the cancer usually increases on the PET scan. BRCA testing is indefinitely associated with increased risk of breast cancer, particularly in families, and is also associated with ovarian cancer. Sentinel lymph node biopsy is the first node to be identified in the operative field of the definitely identified breast cancer in sentinel node. Contrast or dye is placed in the operative field and the first node identified that travels to sentinel node. Biopsy is done routinely in all the patients at the time of lumpectomy or mastectomy. A negative sentinel node eliminates the need for axillary lymph node dissection. Estrogen receptor and progesterone receptor testing is routine for all the patient, and hormone manipulation is done if either test is positive. Treatment generally is by surgery and or hormonal manipulation. Surgery: lumpectomy with radiation is equal in efficacy to the modified radical mastectomy but less deforming. The addition of radiation to lumpectomy is not a small issue. Radiation at the site of the cancer is indispensable in preventing the recurrence of the breast cancer. Hormonal manipulation include the ER and PR positive patient should receive tamoxifen, raloxifene, or one of the aromatase inhibitors like anastrozole, letrozole, exemestane. Aromatase inhibitors seem to have a slightly superior in efficacy. If both are among the if both are options, then it might benefit the patients. All breast cancer should be tested for HER2 new. This is an abnormal estrogen receptor, and those who are positive receive anti-HER2 new antibodies known as trastuzumab, which increases the risk of recurrent disease. Adjuvant chemotherapy is not prophylactic. Since the patient already have disease, it is not the treatment. Since the term applies, there are no clear identified Metastasis. Adjuvant means additional therapy to clean up presumed microscopic cancer too small to be detected. Adjuvant chemotherapy is given when the lesions are larger than 1 centimeter positive to the axillary node. So the things that decreases the mortality in the breast cancer patient is mammography, ER/PR testing, aromatase inhibitor, adjuvant chemotherapy, lumpectomy and radiation, modified radical mastectomy, trastuzumab, prophylaxis with tamoxifen or raloxifene. Thank you.